Good morning, students. In today's lecture, we'll talk about the remaining portion related with anatomy of the vertebral canal. So in the previous lecture, we had talked about its definition and we had discussed about its contents. That is the spaces and the two meningeal coverings we had discussed. Now today, we'll discuss the spinal pia mater and some of the points related with the clinical anatomy. The last content, that is the spinal cord, would be discussed in a separate lecture in detail. So let's discuss about the spinal pia mater, which is the third or the innermost meningeal covering of the spinal cord. It is very thick, it is firm, it is less vascular as compared to the cerebral pia. Now this pia mater of the spinal cord, it has two layers. The outer layer, which contains the larger vessels, is referred to as the epipia, and the inner pia, which is connected with the nervous tissue of the spinal cord, is the pia intima or the pia glia. So in between these two layers of the pia mater, there are small blood vessels and also some cleft-like spaces which connect this layer with the subarachnoid space. This pia mater, it continues below the spinal cord, and that continuation of the spinal pia mater below the spinal cord, below the termination of the spinal cord, is known as the filum terminale. So the filum terminale, it extends from the apex of conus medullaris, which is the termination of the spinal cord, up to the dorsum of the coccyx vertebrae, that is the C1. This is filum terminale is of two types. That is, the filum terminale which is present inside the dural sheath is known as filum terminale internum, and it is 15 centimeters in length. And the filum terminale which is present outside the dural sheath is the filum terminale externum. It is present below the level of the S2 vertebrae and it is smaller in length, that is 5 centimeters. Now there are certain modifications of the spinal pia mater, that is on the anterior side, this spinal pia mater, it gets folded inside the anterior median fissure, and on the mouth of this fissure, it forms a longitudinal band, glistening band, which is known as linea splendens. Posteriorly, it is adherent to the posterior median septum of the spinal cord, and posteriorly it is also connected to the arachnoid by the fenestrated subarachnoid septum. So this is the transverse section of the spinal cord and it is showing the anterior median fissure. So the spinal pia mater is folded inside this fissure, and this is the posterior median septum on the posterior side to which the spinal pia mater is adherent. It is also seen in this figure, the transverse section again. This red lining is basically the pia mater and it is folded inside the anterior median fissure, and posteriorly adherent to the posterior median septum, and this dotted line is the subarachnoid septum which is connecting it posteriorly with the arachnoid mater. Another modification of the spinal pia mater is the ligamentum denticulatum or the denticulate ligament. Present on each side in between the ventral and dorsal nerve roots of the spinal cord, the pia forms narrow vertical ridge. This ligamentum denticulatum, it is known as denticulatum because it has this word comes from dental, so because it has those processes similar to the teeth, it has projection, so it is known as ligamentum denticulatum. So each ligament has 21 processes. Starting from the first process starts at the level of the foramen magnum, and last it ends at the 12th thoracic and 1st lumbar spinal nerves. So this figure is showing the spinal cord, it is showing the spinal dura mater, and it is also showing the arachnoid as well as the very inner pia mater and its modification, that is the denticulate ligament. So these processes, they pass through the arachnoid, they reach the dura, passing in between the two adjacent spinal nerves. These processes, this ligamentum denticulatum, it suspends the spinal cord, it keeps the spinal cord in position in the middle of the subarachnoid space. Now, some clinical conditions associated with the spinal meninges, like leptomeningitis. So, pia mater and arachnoid mater is together referred to as the leptomeninges. So, any infection leading to inflammation of these meninges is known as the leptomeningitis. It is either due to bacterial infection, it is either pyogenic or secondary to the tuberculosis infection. The common symptoms would be fever and symptoms of the related with the raised intracranial pressure, that is headache. There is also neck rigidity and delirium and convulsion in later conditions. On examination of the cerebrospinal fluid, the biochemistry of the cerebrospinal fluid is altered. There is increased amount of protein and other cell contents, and there is a diminished level of sugars and chlorides. Also, the pressure, the intracranial pressure is raised. Lumbar puncture is a very, very important procedure. It has got important diagnostic and therapeutic value. It is used for extraction of CSF from the subarachnoid space. The posture of the person undergoing the lumbar puncture is the person should lie on side with maximally flexed spine. The skin is locally anesthetized. The needle along with the trocar, that is the instrument for collecting the CSF, is inserted in between the L3 and L4 spines. L3 and L4 spines are chosen because the spinal cord ends at the level of the lower border of the L1. So it is safe to insert a needle because there are less chances of injury to the spinal cord. That is why these spines are particularly chosen for lumbar puncture. So a line along the highest points of the iliac spine at the L4 level is chosen to mark the site for inserting this needle. As the needle, when it reaches the subarachnoid space, the CSF is extracted. Now this is an image that is trying to show how the lumbar puncture procedure is done. The position of the person undergoing the lumbar puncture and the site where the needle has to reach to extract the CSF. Now lumbar puncture site is different in case of children and adults. So in children, the vertebral level is L4, L5 because the spinal cord is at the level of the L3 vertebra. So that site for children and for adults is different. Another procedure is lumbar epidural. Through the lumbar vertebra, we have to reach the epidural space so that we can use it for giving anesthesia or analgesics, and the epidural space is quite deeper in the midline. Now one procedure is lumbar epidural, another is caudal epidural. Caudal epidural because caudal is tail, so we reached almost the tail portion of the vertebral column. and through that we are trying to reach the epidural space for the same requirement, that is for giving anesthesia or analgesics, but we are using the different mode of reaching to that epidural space. We are reaching the epidural space through the sacral hiatus, which lies equidistant from the right side and left side posterior superior iliac spines. Needle would pierce, or it passes through the posterior sacrococcygeal ligament, and it will finally enter the sacral canal, and at the space will lie below the S2, that is the second sacral. We have to reach the second sacral, lower border of the second sacral vertebra in order to reach the epidural space. The hub of the needle is lowered so that it can pass the sacral canal, and this figure is demonstrating how the caudal epidural is performed. So this is a needle inserted inside the sacral hiatus, this opening, and slightly bend so that it can reach into the canal. Right, in this procedure it will pass through the posterior sacrococcygeal ligament. This is sacrum and coccyx, so it will pierce that ligament, it will pass through the ligament, and it will go inside to reach the lower border of the S2 vertebra. So with this we come to an end. We have discussed its contents and the spaces, and the last content, that is the spinal cord, it would be discussed in a separate lecture. So thank you so much.